There are two strategies to integrate plasma-based testing into clinical practice. Right now, I think the dominant way that it's being used is for the patient who, for whatever reason, can't get a tissue-based test. There isn't local availability of the appropriate testing modality, the patient declines it, patient or doctor are afraid of side effects or complications of that biopsy, to bring molecular testing to a population for whom it's not currently available. But these tests are getting more and more validated every day, and the turnaround time is getting faster and faster every day. So if in a world where there's a several-week turnaround time to a non-tissue based test, I'm not willing to wait for that result to then consider tissue-based testing because lung cancer can hurt a patient in that time span. But these tests are getting really fast. We're just about at an era where these results can come back in a matter of days. When you're talking about a matter of days, now the risks of biopsy might exceed the risks of waiting. And that is an era that in some places we're in other places we're rapidly entering. And in that kind of a world with good validation and very rapid turnaround, there's a new strategy that I'm actively considering moving to. And that strategy would be that any time that I want molecular characterization, whether it's upfront or at the time of acquired resistance, the new strategy would be to get the plasma-based testing. It's a few-day turnaround, get results. If I get an actionable result, for example, in an EGFR mutated patient with acquired resistance, I get T790M, action it. In contrast, if I get no result back, non-actionable result, then I'm at that point going to move into tissue-based testing. And there's one caveat here for very recent data that may be worth commenting upon. There was data shown recently at the European Lung Cancer Conference looking at results of plasma and tissue-based testing for the use of third-generation TKI. And in looking at the patients whose plasma result was negative, so they didn't find a result in plasma either because there is no T790M in that plasma, or in some cases because the tumor doesn't shed DNA, a non-informative result, they subtyped those patients with the negative plasma into those in whom the original sensitizing mutation was found, a population where the cancer probably is secreting DNA and there just is no T790M, versus those for whom no molecular result could be found, that the original sensitizing mutation you know is present in the cancer wasn't there. And as you might expect, those whose cancer were shedding DNA, who had the original sensitizing mutation but not the T790M, had a very poor result with the third generation TKI, where those who had an uninformative result, no DNA being shed, had better results. And so it may be that the presence of the original classical mutation can help you in understanding if you're just failing to find a mutation or if it's just not there. If I get a negative result on plasma-based testing in an upfront patient at new diagnosis, then I'm going to get tissue on every patient. And the location of tissue acquisition, it just has to be cancer. Any spot is fine. Classically, when we were using PCR, we avoided bone. It can be a little bit of a problem with next-gen sequencing, but much less so. So if there's a non-bony spot, maybe you get a non-bony spot. But mostly, my decision is about safety and comfort for the patient for where I'm going to go after it in the first line. In contrast, if you have a patient with acquired resistance to a targeted therapy and you're trying to understand the mechanism of that acquired resistance to try to get the patient a next-line targeted therapy, then if I get a negative plasma result, the first thing I'm looking to do is see whether the original sensitizing mutation that I know to be present in the cancer is there or not. And this is important to me because if I don't find that original classical mutation, then I know that this cancer is not secreting DNA in a way that I can find it. And that makes it mandatory for me to then get tissue. In terms of what spot to get tissue for, I'm still thinking about patient safety, I'm still thinking about patient comfort, but the additional factor that I'm adding in is that you really want to biopsy a spot that's growing, because there can be heterogeneity inside of the patient where some spots of cancer are still sensitive to the original TKI, where others have this new resistance change. And if what you really want to know is what that resistance change is, you have to put a needle in the spot that has that resistance change.